I don't think I apologize. The delay did not get done, but you have to look at the delay. And for this patient, if you looked at the delay, and we can upload it for you also, but essentially this is beautifully filled with contrast and you don't see anything. Now, what is notable if you look here is you see right here, this patient, this is all dark here, that's all contrast. So this patient had a hypoplastic left ventricle that is fully filled with contrast. That the only communication to this ventricle is through this tiny little VSD, which is why there it has thrombosed off. So this is a thrombosed off tiny hypoplastic ventricle. This is a patient, and again, we just can't have everybody playing this, but you essentially, we do a nice here biventricular scan. So again, this is essentially modifying how we do our coronary scan for like an injection protocol, and instead we are just adding more contrast. We're elongating how much time we're giving contrast for, so we get a biventricular scan. So this is using twice the amount of contrast that we typically give, but we get a beautiful biventricular injection, and we can get looking at the right side of the heart. So one of the new things that is come in the congenital world is putting in valves in the pulmonary position. And for native outflow tracts, Medtronic has a Harmony valve, and this is the Harmony valve in this position. And so this patient had free pulmonary valve regurgitation, and they did not want surgery. And one of my concerns always has been with the Harmony valve is we know all pulmonary valves get infected. And what is going to be our plan when it does? And everyone kept saying, you know, the initial trials, there really weren't any Harmony valve infections. But everybody knew it was a matter of time before we'd start seeing it, and we are now seeing it. So this is a valve in the native outflow tract. So this valve goes into the RVOT, and they typically go pretty deep into the RVOT, and then they also splay out into the branch pulmonary artery. So kind of the main PA, and they go just to the base of the branch pulmonary artery. So it's a very big valve to be able to be held in place. And this is a patient who had staph endocarditis. They were at an outside hospital that they presented with chest pain, shortness of breath. They were diagnosed with pneumonia. They got an echocardiogram, and the echocardiogram was essentially non-diagnostic at that institution, looking for the pulmonary valve. So they didn't see anything. And then they had they had a transesophageal echocardiogram, which again, the people that were doing it weren't used to looking at pulmonary valves. And so again, they cleared the patient and said there's no endocarditis in this patient, but they were having persistently elevated staph bacteremia, and that's when they finally reached out to us. So we transferred the patient here, and this one you can see by echocardiogram, but you can really see it beautifully also by CT scan. And so we've really stopped doing transesophageal echocardiograms for pulmonary valve endocarditis, just because we can see this so much better. And by TE, it really is because you get so much shadowing artifact from the Harmony valve. You really can't see stuff by TE, but we get beautiful imaging for endocarditis by CT scan. And so especially for the pulmonary valve, our standard is we just start with a CT scan, and only rarely do we move on to a transesophageal echocardiogram. And so you can see this mobile mass here. Some of the things that I've learned over the years doing a lot of pulmonary valve endocarditis studies is it can be really hard. Sometimes, like here, this is pretty obvious. You have a mobile mass. Sometimes all that happens is you just get thickening of the pulmonary valve. And so it can look like just like Holter ham that you would see on an aortic valve. And I've seen even an aortic valve endocarditis cases with TAVR valves where they were read as Holter ham on the aortic valve. But it was a new valve. It was a new thickening, or sometimes you don't know like what the time course was, but they were having persistent bacteremia. And so if you only have thickening, a PET scan is really going to be your best option, because getting echoes and TEEs aren't going to show you anything more than what we have. But if you do a PET scan in the entire when they're really infected, the whole thing will just light up and be super bright on PET imaging. That'll be then a sign that your valve is infected. And so that sometimes is where I've seen people get themselves into trouble, is that it'll look just like a thickened valve, but it will indeed be infected. And these patients typically are pretty sick, and they typically they're screaming endocarditis and they have a prosthetic valve, and you're like, I really feel like there's endocarditis here. That really is your best option, is going then to a PET scan. But we always start with a CT scan for these patients. Any questions here?